Well, again, my name is Randy Jones. I first want to just thank you all for being here and for inviting me to speak to you all today. I'd like to thank those members who I've been in close contact with and those departments, and also, inner life, symptom management training, and Mary, all those individuals, and Dr. Grady for just inviting me and just being a part of helping junior faculty, senior faculty to be able to get grants and to be able to move forward their science or research. So appreciate all the time that you all are dedicating to this. I'm going to speak to you all today about prostate cancer and treatment decision-making, part of my program research. As outlined, I'm going to talk to you a little bit about my education and clinical background, as well as move into my program of research, and then professional career and trajectory. So in my clinical background, I was dealing with mental health as well as oncology. So within my research, I'm blending the two, looking at psychosocial behaviors, particularly to cancer patients, but also I've worked with other chronic illnesses such as diabetes and breast cancer. Also with the overarching umbrella being health disparities. And within a personal note, as far as what drove my clinical interest, it was mainly my uncle. He had died of prostate cancer, and when I was pretty young, and I was always wondering. He never really told anyone that he had died. He had prostate cancer, and then I was wondering why didn't he really tell anyone that he had prostate cancer until maybe only 2 weeks of his death. And it was kind of interesting to me why this wasn't really known or wasn't talked about within our own family. So, and then by the time I got into nursing school, that's when the research bug kind of started coming to me saying, oh, well, that would be something that could actually investigate a little bit more. Why within this particular population, why individuals and why that stigma may be with prostate cancer in particular. So that was the driving point within why I decided to move into prostate cancer specifically. A little bit of background, as many of you will know, that prostate cancer is the second leading cause of cancer deaths among all men, and it usually affects individuals in the later stage, but as we know, there are aggressive cancers that also occur in individuals who are younger. African American men have the highest incidence rates and prevalence and also mortality rate than any other individuals, as well as the mortality rate is really significant within African Americans, and it's multifactorial why individuals are actually dying of prostate cancer, as well as having the incidence of prostate cancer. Some people say that is because of diet, lack of education, lack of resources, all those type of things that have been discussed today, those social determinants that may be incorporated into why individuals are acquiring as well as dying of this disease. And as we know, cultural beliefs have a particular interest within decision-making opportunities. Individuals sometimes rely on certain members within their family. Some groups of individuals have different roles that they play within family dynamics that also determines how they make certain decisions. So that comes a part of effect when we look at race or other ethnicities that may not be considered minorities. Here you can see this information is from the SEER data, and you can see within African American, white, and Hispanic, within African Americans, the incidence rate is quite high. We're looking at 1.5 to 2 times as likely to actually have prostate cancer, and those individuals who are African American are 2 times as likely to die than any other ethnicity group. When we compare it to whites and Hispanics. So again, the information here is quite dire that prostate cancer needs to be examined in different aspects to see how can we be able to decrease that gap. I'm going to move on to telling you a little bit about my program of research and some of the prior studies I have conducted. One of my first projects dealing with prostate cancer looks at prostate cancer screening decision-making among rural African-American men. And this grant was supported through the University of Virginia Rural Healthcare Research Center. They had a P30 grant that I was able to receive, and you can see through NACNR here. So the 2 aims for this particular study was to describe how rural Black men made the decision to have or not to have a prostate cancer screening. Also, to identify facilitators and barriers in the prostate cancer screening decision-making process for rural Black men. This design was a qualitative design looking at a hermeneutic phenomenological approach basically looking at the lived experiences of these individuals and how it relates to their own aspects of prostate cancer screening. Quickly, some of the research procedures. We utilize a digital recorder for interviews. Those interviews were transcribed. The interviews last for an hour, hour and a half. And many of you will say hour and a half is pretty long for an interview. But as I started to go through these interviews with these individuals, they really opened up and wanted to talk. This was kind of their avenue in actually relating to someone that looked like them, someone who actually could relate to them in an aspect of prostate cancer. Also, these individuals felt like even though some of these individuals were married, that they didn't feel as comfortable talking and divulging all the types of things that were going on in their minds, and particularly the stigma behind it, and particularly the roles that they may play, and they didn't feel that that role may be compromised if they divulge too much to their spouse or even other loved one. And I use a qualitative software called In Vivo within this, and $30 were compensated for their time and travel. Within the recruitment efforts phase, I basically went to areas where we could find African-American men. And looking at the area that we were looking at for this, within this study, barbershops was a big one for recruitment efforts, churches, rural community health centers, radio stations, and recreational centers. We got a lot of reply back from those individuals that were in barbershops, but also within churches. Not as much within when you advertise through the radio station or recreational centers. Within this sample, we acquired 17 participants within the study due to study saturation. And these individuals had to be at least 40 years of age or older, consider themselves to be African American, have never been diagnosed with prostate cancer, and have the ability to have informed consent. And basically, I interviewed these individuals in an area that they felt mostly convenient, such as their home or a conference room. Most of these individuals, they preferred their home. You can see the age range between 40 to 71 with a mean age of 52. Most of these individuals had a high school degree or below, and the majority of these individuals also had a $30,000 annual income or below. So qualitative data analysis was conducted, looking at those recurring themes that emerged from some of the categories, as well as some frequency data and descriptive analysis were also done for those demographics. So the themes that actually emerged were 3 of them. So limited education about prostate cancer was one theme. These individuals didn't realize that some individuals thought that prostate was in women as well as men. Some individuals thought that they didn't know the recommendations for actual prostate cancer screenings. Some people didn't know that Black men actually were more expected to potentially have increased risk for having prostate cancer. So there was some lack of education there. As well as family involvement was another theme that came out, and importance of family and prostate cancer screening decision-making. So these individuals relied on certain members of their families to help them with certain decisions within their life, as well as having a partner to be able to talk about certain aspects that they may not feel comfortable with, talking to, such as like a friend or a pastor, so forth. And then also the necessity of trust in healthcare provider, which we've seen in the literature before, that individuals who really cared and trusted for patients and those men who really felt a connection with the healthcare provider actually opened up and was able to help make a certain decision that was good for them. So the implications for that particular study was looking at how to sustain and improve care to deliver to a vulnerable population, particularly including the family in the decision-making process. Oftentimes, as healthcare providers, we may not include all the family members or the patient. We may not ask the patient, is there someone else that you may want to bring in to help make certain decisions with you? Also, the development of a culturally sensitive decision aid to be able to find, we know that certain interventions aren't done well for certain populations, so making it more culturally sensitive, as well as try to improve those relationships with African American communities and break down some of those walls that we have when we talk about minority individuals. And one thing that was mentioned today as well, try and make it a welcoming environment, using less jargon within clinical settings, making sure that patients understand what is actually going on in a clinical setting, so that when they walk out, they can say that, yes, I understand what was actually repeated or stated to me. A subsequent study my team received a grant from NCI that was funded for R21 that focuses on a decision aid for patients with advanced prostate cancer to help facilitate informed shared decision, particularly as it relates to quality of life. And the study was also NCI as well as a supplement grant from the Cancer Center at the University of Virginia. A little bit of background for advanced stages. Within almost all patients with advanced prostate cancer, they become refractory to hormonal therapy. So their advanced prostate cancers have a poor prognosis. So we can see that there's limited treatment options out there for advanced stages, which we've seen within the literature. Sometimes men with advanced prostate cancer feel like they don't have many avenues to go to. So we decided to try to figure out how can we create a decision aid that is sufficient for them, as well as they feel that they're satisfied with certain decisions that they make towards, particularly the end of life. So within this study, the aims were to determine feasibility in implementing a decision aid, as well as to gather data for a hypothesis that patients with advanced prostate cancer and their caregivers who receive decision aid to enhance decision-making skills about cancer treatment will increase quality decision-making, decrease decisional conflict, and as well as increase that decisional satisfaction. This is a mixed methods design, and we use a quantitative approach, being pre and post, as well as we also did a qualitative methods at the very end to kind of get a sense of what these patients really felt about the decision aid. We also included within this particular grant the caregiver being the support person, the person that they felt most comfortable with, helping making decisions. And then at the end of the study, the patients, again, as I mentioned, they were interviewed by telephone or in person. Most of the individuals, they asked to be on telephone because within this group sample, this was in a rural community. So individuals maybe drove an hour, 2 hours into the clinic in order to provide good care. So we decided to have also telephone interviews as an option. And these interviews lasted for approximately an hour. These individuals had about 22 dyads, being patient or the support person. And these individuals had to have at least advanced prostate cancer with a 6 months expectancy. So you can see within the mean age for these patients was approximately about 71 years of age. For education, a little bit higher than high school. Also for the support person, they're a little bit younger, 63 years of age, with education a little bit higher than the actual patient or participant. And most of the individuals were married. We had, for the support person, majority was female, and we had maybe one or two that were actually a male support person. And then the majority of individuals were Caucasian within this sample. So within the qualitative findings, 3 themes came out. The decision-making aid helped to understand treatment decisions. Also, these individuals felt that by utilizing a decision aid that kind of broke down how to create a decision, how to make a good decision for them, not necessarily for the support person or for the healthcare provider, made them understand what type of treatment options were really out there and how they can be able to be more satisfied with that decision. As well as the decision to help the patient and support person to be more involved in treatment. This is kind of a time where we saw that the patient support person actually felt that they were part of the team, closer to that person's life, because they felt a little bit of distance beforehand when they went to the healthcare provider. But by utilizing the decision aid together, it felt like things were coming out that they hadn't really realized that was going on with the patient. So it really brought this team patient-centered approach together. As well as frequent contact with the study nurse was invaluable. Having another person in place to be able to throw ideas out with the patient and the support person was really valuable for these individuals. They felt that having a liaison between the healthcare provider and them really helped them a lot. So the implications for this particular practice in the study was that it may heighten healthcare providers' awareness of utilizing decision aid for advanced prostate cancer, as well as healthcare providers may see an increased value in patient support persons becoming more involved in that treatment decision. And most recently, I was fortunate enough to be a part of the Robert Johnson Nurse Faculty Scholar Program. And within this study, we looked at the use of a decision aid in a modified for patients with advanced prostate cancer and their chosen supporter, as well as looking at a transitional proxy. Transitional proxy being an individual being the support person to be able to help make decisions when potentially that patient may have cognitive impairment or may feel like they can't make a decision because of some other type of treatments that they're receiving. So the findings for this particular study was that the decision aid facilitated understanding of the treatment options. Quality of life was more important than quantity of life. This really came out because oftentimes what we've seen that in the past, patients have been saying that felt like their healthcare provider was kind of telling them we need to push on, let's give a little bit more chemotherapy or a little bit more hormone therapy in order to get you a few more weeks or a few more years out. But within some of these patients, it felt like really quality of life is really what I want. It's not necessarily how many years or weeks I can extend my life, but actually the quality of that. And also thinking too, how did the support person view that? Some support persons felt like they wanted their loved one along with them on this earth longer, but the patient may say, really, I'd rather have a short amount of life, but quality. And then also contact with providers greatly influenced the decision. Being able to have that trust with the provider really impacted how they decide to move forward in their treatment options. So within the next steps in my program research, we recently submitted a multi-arm, multi-site randomized control trial for R01, throwing positive energy out there, for further test the use of the decision aid to look at advanced prostate cancer along with a support person and utilizing a community health worker. And we decided to utilize this community health worker, bring this in mainly because, again, seeing that patients really love to have another line, another person being the liaison between the healthcare provider and the patient. And from some other studies that we piloted utilizing community health worker, other individuals kind of love that idea. So we decided to maybe place this within advanced prostate cancer and then seeing how the community health worker is actually impacting this particular decision. So some of the connections here from the start to the proposed R01. You can see pilot study focused on the prostate cancer screening, decision-making, health disparities. Then it moved on to the R21, looking at advanced prostate cancer, seeing that within the literature there was a dearth of information out there that really focused on that advanced stages, palliative care, end-of-life aspect, and utilizing a decision aid for that, looking at how feasible will it be in a clinical setting. Then within the RWJF grant, focused on the prostate cancer, advanced stages of prostate cancer, decision aid feasibility, but also bringing in that transitional proxy aspect. And then this proposed R01 focused on the advanced prostate cancer decision aid, bringing in a community health worker and a multi-site. So hopefully we can be able to see how well this decision aid has been culturally tailored enough to actually help patients feel comfortable with the decision that they make, utilizing certain aspects in their life, such as the community health worker, psychosocial aspects, and some other factors that may come into play. Some about my professional career and trajectory. Currently, I'm the baccalaureate program director at the University of Virginia School of Nursing, so I overlook about 400 or so students. And I have a great team that we work together, and we make sure we try to bring in undergraduate students, particularly into research, start off while they're still in as a baccalaureate program, and then help them move on to potentially a master's and PhD. We try to include nursing students within several of our faculty research and to make sure that they have a good standing when it comes to knowing about undergraduate research. And then also to continue to I want to continue my program research as well as involve other students and junior faculty, particularly those who are in minority status, to be able to bring in more individuals who are like-minded, thinking about health disparities, health equity, also bringing it from all different levels, particularly in the community, trying to make sure that individuals in the community see that what research is actually impacting in their lives. And then continue to be involved in interdisciplinary boards and to enhance the healthcare and research and collaborations. As Dr. Roy mentioned, we need to be able to go across lines, not just only look into nursing, but also other disciplines in order to make the research rich, and then also make sure that we can be able to get the most impact within the research aspects that we have. So I'd like to thank you all for your time and efforts, and I'll open up to any questions.